All right, so diagnostic tests. So what are some diagnostic tests we can do? So kind of recapping all the things we've been talking about for rhabdo, for UTIs, for ATN, for pre-renal failure. All these things are kind of coming together right here, right? So chemistry, obviously that can tell you about your BUN creatinine, right? So BUN creatinine is going to tell you about your kidney function. And you can look at the different levels of BUN creatinine, right? So normally one of our ways to fix a pre-renal failure being caused by what again? It's a lack of blood flow, lack of perfusion to the kidneys, right? One way to improve that is, the RAS system fires off. The RAS system fires off, you absorb sodium and water, right? So where sodium goes, water goes, right? But also the RAS system and the SNS for that matter are going to stimulate the release of ADH or vasopressin, right? And that's going to go on down to the kidneys, to the very, very last bit of the kidneys, and it's going to tell the kidneys to absorb BUN. So BUN will be taken from the urine and put back in the bloodstream. And where sodium goes, water goes. Where glucose goes, water goes. Where BUN goes, water goes. So that's what's going to cause a rise in our BUN more than someone with intra-renal failure. So in pre-renal failure, you have a BUN creatinine ratio that is greater than 20 to 1. Okay? So normal is 12 to 20 to 1, so creatinine to 1, BUN to 20. But if it's like 30 to 1, that means that your body was holding on to BUN for some reason. Okay, and we'll talk more about BUN. There's other reasons why your BUN can go up. A GI bleed, for instance, steroid use can also make your BUN go up. But if you're not on steroids, you don't have a GI bleed, and the BUN creatinine ratio is greater than 20 to 1, that means you have pre-renal failure. End of story. All right, there's no other reason for it. Okay, and then we'll still talk about BUN creatinine specifically because they deserve some time. All right, but electrolytes, you're worried about potassium, right? And we want to look at the calcium, phosphorus, mag. Why calcium and phos? Spillage from, or phos specifically, from like rhabdo, for instance, right? Also with chronic kidney disease, when we start talking about chronic kidney disease, calcium and phos get more affected. Usually we don't talk about calcium and phos until we talk about chronic kidney disease. It doesn't really it's not really affected acutely, but BUN creatinine is affected acutely. All right, so creatine kinase and myoglobin, if it can be run, are going to tell us about rhabdo, right? And the lights for rhabdo again were PLUK, right, or PLCK. Or PCK, right? So we got, our potassium is high, our phosphorus is high, our calcium is low, and then we add on our CK, for instance, right? What else? So urinalysis, we talked about pyelonephritis, right? So you might have a UTI, it could be causing your renal failure. So, renal and urology should be involved once you see a creatinine elevation, but urology definitely needs to be involved with what kind of renal failure? With any kind of, not intrinsic or intrarenal, not pre-renal, they don't care. They care about one thing only, and that is post-renal failure, right? And what they're going to ask you is, what did the renal ultrasound show, or what did the CT show? And what are they looking for? They're looking for hydronephrosis, because that tells them something's blocked, and they need to get up out of bed at 1:30 in the morning and come over and fix it and figure out why it's blocked, right? And if it's just a Foley catheter, they're definitely going to tell you, hey, just can you flush the Foley catheter for me and let me know how it happens? Because it could just be a Foley catheter, it could be something simple, okay? But, sediments can lead to stones, right? There's different kind of stones we'll talk about that can cause a buildup and cause a blockage of the urinary flow, okay? So what else can happen? So we can have proteinuria, microalbumin. Microalbumin usually you're looking at more of a chronic kidney disease situation. We'll talk a lot more about microalbumin with chronic kidney disease. It tells you how bad your kidney failure is, how bad your glomerulus is, right? Because you're losing nephrons. And how many nephrons do you have? About 1 million per kidney, right? And you start losing nephrons, is your kidney get bigger or smaller? It gets smaller. So the renal ultrasound, it can show like a raisin, right? Or a prune, or a fig, or a date. I don't know, whatever dried fruit you like, right? Or an apricot. All right. Anyways, I'm hungry. Anyways, we have, which those guys also have high potassium because all their cells are breaking open as well, right? Anyways, we have CKD. Has a really, really small kidney, right? Has a dried up prune-like kidney. Whereas hydronephrosis has a huge kidney, okay? And the microalbumin, that's really going to be indicative of, CKD. With proteinuria, though, it could be your kidney is really, really damaged and really shot. You already have history of kidney disease, but proteinuria can also be, we kind of mentioned in passing, with glomerulonephritis, right? Our glomerulus is literally being attacked acutely by some kind of autoantibodies or immune process, right? So that's something to look at acutely, because if you lose protein acutely, what happens? It's just like ascites, right? It's just like liver cirrhosis. You're losing protein in the urine. And they can be anasarcic, they can have anasarca, they can have ascites, they can have facial edema, and they eventually have a low blood pressure, right? At first, they're going to have a high blood pressure because they're going to be trying to compensate for this low volume. All the SNS and RAS can start kicking in, but they're a risk for pre-renal failure, ironically. Okay, what else? So additional labs. So we have certain nephrotoxins that can cause damage to our kidneys, right? So vancomycin being one, aminoglycosides. What are aminoglycosides as an example? Like something mycin, like every antibiotic is something mycin. What is it? Pleomycin? Gnats. Gnats with a G, right? So GNATS, those are all of your aminoglycosides. So gentamicin, neomycin, amikacin, and tobramycin. Those are aminoglycosides. Okay, because there was no meeting in a top mountain somewhere where they decided how to name antibiotics. They all like made their own names and they came to the mountain. It's like, oh shoot, we should have thought about this ahead of time because everything's ended in mycin, unfortunately, right? And then cyclosporines and tacrolimus. These are tacrolimus is for kidney failure rejection, or when you get a kidney transplant. And also other organ transplant things that we have to be alert to. That can, if they have a history of organ transplant, they're probably on tacrolimus and maybe some steroids too, and for the first bit of the post transplant. But they can lead to toxic levels, and that can lead to kidney damage, ironically. Okay, and then renal ultrasound and bladder ultrasound. We mentioned the importance of that, right? Looking for hydronephrosis, looking to see if you have tiny kidneys or polycystic kidneys. What is polycystic kidney disease? It's a genetic thing, right? So it's where you get kidneys that get all these cysts, not cysts like infectious cysts, but cysts that are full of fluid, right? So polycystic kidney disease is full of fluid, and like collagen areas and other areas like your brain, they get aneurysms, and your aorta get aortic aneurysms. But in your kidneys, they just swell and swell and swell, and they get up to hold up to like 5 to 6 liters, like ridiculously huge kidneys. Okay, so they could have PKD or they could have hydronephrosis, which is more common. Okay, and then urine electrolytes. So we'll talk about electrolytes in more detail coming up, but you can imagine this is going to be talking about the sodium and your urea primarily, right? So what well, urea is not an electrolyte, but we can look at what happens with are the kidneys working or not, right? When the RAS system fires off, aldosterone is part of that system, right? And it goes down to the kidneys, and what does it do? It tells the kidneys to do what? Aldosterone to not diurese, which means it's doing what? It's how does it not diurese? Huh? Shrinking? No. Constricting what? That's you're thinking of angiotensin 2 is going to basically constrict. But aldosterone does what? It does exchanges sodium for potassium, right? It puts sodium where? Normally.
Puts sodium back into the bloodstream.
Puts back in the bloodstream, and water follows, right? So sodium is taken from the urine, is put back in the bloodstream. So what is the urine sodium going to be if aldosterone is working? Low, right? So when you have a low urine sodium, that's indicative of pre-renal failure, right? So they have a urine sodium that is, right, it's really small there, but we'll get more into urine sodium later. So you can tell whether it's high or low, right? And if it's low, that's pre-renal. Pre-renal, okay? So urine sodium, so here pre-renal failure. All right, urine sodium was less than 20. That makes sense because aldosterone's working. Our aldosterone's doing its job. It's going to the kidneys, going to going to the collecting ducts, and it's telling it, hey, don't get rid of that sodium. Exchange potassium, take the sodium from the urine, and water will follow, and hopefully blood pressure will be restored, right? And then what else can happen? You can have if we have intra-renal failure, are the collecting ducts working? No, they might be dead, right? There's no one home, right? So you can release all the aldosterone in the world, but it's not going to reach that collecting duct, and it's not going to work. That nephron's not working, so it's unable to concentrate urine in intrarenal failure. Okay, so if you have unable to concentrate urine, well, are you able to hold on to sodium? Are you able to take sodium out of the urine? If you can't do it, no, right? It's going to stay in the urine, right? So you have a urine sodium that is elevated in intrarenal failure. Okay, so intrarenal failure, you can see it's greater than 40. And then urea, we talked about ADH, right? ADH holds on to urea. That's one of its ways, its tricks to hold on to more water. Is it will take the urea molecule again at the collecting ducts. It'll take it from the urine and pull it back into the bloodstream. Water will follow, and that will hopefully restore blood volume, right? So we can think about it. If they have pre-renal failure, is ADH working? Are the distal tubules working? Is the collecting ducts working? Yes, and if you have pre-renal failure, they are working, right? They are responsive to aldosterone, they're responsive to ADH. So therefore they work, and therefore the urine urea will be what? If ADH and aldosterone are working. We're looking at the ADH piece. Normal, maybe, but it's going to be definitely which direction, high or low. What did ADH do? It took the urea out of the urine, right? So all you have is in. No, I'm kidding. All you have is you have a lower urea, right? So same thing. Pre-renal, I should use a different color. Pre-renal is also going to be a low urea, okay? And just vice versa. You're going to have a high urea or a normal to high urea when you have a intra-renal failure, because ADH is being released, is trying to work on the kidneys. The kidneys don't work, so they're not responding to ADH. Therefore, urea just makes its way into the urine more than usual. All right, so it'll be high, and you can apply this to specific gravity as well, because specific gravity has to do with ADH, right? When ADH is around and it's doing its thing, what should the concentration of the urine be, which is just specific gravity? Should be more concentrated if ADH is around, so it should be higher, right? So specific gravity can also be applied here. And biopsy might be needed if we have like a tumor compressing our kidneys. These are the reasons why we might have to, figure out what's the reason why someone has AKI, right? When someone has pre-renal failure, it's easy. Fix the shock, right? Fix the perfusion, fix the heart, right? That's easy, right? Get a new liver, right? What's going on? Why that's so hard, right? But when you have intra-renal failure, we got to do all kinds of tests to figure out why your kidney is not working, right? Do you have rhabdo? Do you have ATN? Do you have nephrotoxins? Do you have something weird like a lupus disease? Do you have an autoimmune situation happening, right? And they might need to biopsy in those cases. Okay, so rhabdo we talked about. Sepsis we can cause pre-renal failure, but sepsis also just makes it so many organ systems don't work, right? So that can be, it kind of overlaps in that case. All right, so BUN creatinine. So BUN creatinine, BUN is going to be made from protein breakdown, right? So urea, blood urea nitrogen, that's what the U stands for, right? So what does that do? It's only benefit in the body, because it is waste products, right? Its only benefit in the body is to absorb water, right? In the presence of ADH. So when ADH is around, so ADH comes around to play, it's going to stimulate the absorption of urea. And wherever urea goes, water follows, and that will help restore our blood volume. So that's the idea of what ADH is, and that's how it works on the kidneys, right? So urea is made from protein breakdown, right? So protein's broken down, and then we get I think it's two amine groups, which make up your your proteins are made of amino acids. Amino acids have NH2 in them, so you got two amino acids broken down there, and they're attached to a CO2 molecule, right? And then we have a BUN molecule, right? It's been nicely packaged by the liver, and it's on its way to be transported to the kidneys to be excreted, right? And ADH is like, whoa, they're gonna dumpster dive. Like, oh, no, this is still good. It's not expired. What are you talking about, right? I can use this urea later, right? And then water will follow it. Okay, so we talk about liver failure. Liver failure, we have this process is broken down somewhere in there in liver failure, right? We can't form BUN nicely, so ammonia builds up in liver failure, right? But either way, BUN builds up when you have breakdown of what? Breakdown of proteins, right? So proteins are everywhere in the body. You can break them down. They can be broken down by only one hormone in the body. Only one hormone will actually start breaking down your proteins. Your other hormones don't do this. So the only hormone that breaks down proteins in the body is what? It's called gluconeogenesis, right? Making glucose sources from non-glucose sources. It's there in a pinch for when you need to have energy. Glucagon is just storage of glycogen, right? That's just glucose storage. And we can break down lipids as well, right? Epinephrine, growth hormone, glucagon, they all break down glucagon for glucose stores and lipids for lipid stores. But there's only one hormone that breaks down proteins, And you don't want them to break down proteins because that's for hemoglobin, that's for muscle stuff, that's for collagen, right? You can cause bone fractures, it could cause all kinds of problems if you start breaking down proteins chronically, right? Especially in the ICU setting. So what's that hormone called? It raises the glucose. It's also known as comes from the adrenal cortex. So it's a glucocortex or a glucocorticoid or a steroid, right? So steroids also are going to cause protein breakdown or proteolysis, lyse proteins, right? So if you have steroid use, you're going to see a rise in which number? Rise in the BUN, right? So that's something I can explain. It's like, oh shoot, they got a GI bleed. Well, steroids can cause a rise of BUN, but also steroids can cause GI bleeds, right? So it's like, well, which one came first, right? So we're just going to be hyper alert. And if someone's on steroid therapy, that's why you also add what to their menu? Acute is a good idea, right? So they heal well, but also we're going to add on PPIs. Okay, so we know there are risks for ulcers with steroid therapy because it's going to break down, it's going to prevent the production of prostaglandins. And if you do that, it's going to cause higher risk for gastric acid release and cause more ulceration. So we give Protonix or pantoprazole therapy or PPI therapy for someone on steroids. Right? If someone's on steroids, you're going to break down proteins throughout the body, and your BUN will go up because of this process over here, right? But what else might make your BUN go up? Is just I thought I had a turkey on here, just a big meal, right? Just with an increased meal after Thanksgiving, everyone's BUN goes up, right? If they partaked in turkey, right? All their BUN will go up acutely over the next 24, 48 hours. And then you will break down that excess protein because you're not working out, right? After you have a Thanksgiving meal, right? If you started working out, like this grandma right here, you start working out, you're going to make use of that protein and you're going to store it away as myosin and actin and make more muscles, right? Or muscle tissue, more dense muscles, I should say, right? But if you don't, then you're just going to it's just going to get broken down and peed out, okay? So BUN can go up with protein loads, right? What's another protein load that might happen with someone on steroid therapy? Or someone who has esophageal varices, or someone who has Borhaves, or Mallory-Weiss tears, or has GERD, or ischemic colitis, or mesenteric ischemia. What might happen? You might get a GI bleed, right? So blood has what in it? Has heme, and it has globin, right? So hemoglobin, and the globin is a protein, right? So that's a Thanksgiving meal right then and there, right? So what do vampires eat on Thanksgiving? They just eat more blood, right? So that's going to be a bigger protein content, right? And their BUN will go up. And we kind of mentioned this in GI that if it's greater than 30-1, that's a GI bleed until proven otherwise. Okay. Especially if they have symptoms. They got hematemesis and your BUN is greater than 30-1. It wasn't just because of because they had red jello. That wasn't the reason, right? The reason was most likely because they have a GI bleed happening. Okay. If it's greater than 20-1, that's what we talked about pre-renal failure. Okay. And can a GI bleed cause pre-renal failure? Yeah, if it's a GI bleed is bleeding enough, right? It starts bleeding and bleeding and bleeding and causes hypovolemia, then yes, you can get pre-renal failure out of it. Okay, all right. So BUN will go up with protein intake and with steroid use. It'll also go up with dehydration, right? Dehydration just concentrates everything in the serum. So your BUN will go up, and your creatinine will go up as well, and your sodium will go up. And when you start giving fluids, then that will restore, and your numbers will come back to normal, right? Or back to their baseline at least, right? Because you said creatinine does not change acutely, but if you have a dehydration, you're actually making it more concentrated. When we measure creatinine, we're measuring the concentration of it, not the actual production or the total amount of it. Okay, so usually after fluid resuscitation, then that's when you can say, oh, that's what their BUN creatinine is. Okay, so in AKI, if they have, they're like creatinine is like 4.2 and the BUN is 56, you're like, oh shoot, they have a pre-renal AKI, and then we got to start dialysis and we got to do this X, Y, and Z. So then you give fluids, and bam, the next day the creatinine is 1.1 and the BUNs come down to 22. It was just fluids. That was the only reason why they were their numbers were high, was because they were concentrated, right? But if you give fluids and the next day the creatinine is still 4.2, you have an AKI on your hands. That means that dehydration or whatever else has precipitated to the point where it caused an acute kidney injury. Okay, and we talked about why BUN starts climbing significantly is because of our ADH over here, right? ADH is going to go to the distal tubules there, the distal portion, which is the collecting duct. It's the whole portion right down here. Our collecting duct is going to, respond to vasopressin or ADH when it's around, and it will absorb water. It doesn't like just open up like a dam and the water flows. No, they have to do some effort. They have to, put some urea on the other side and just kind of coax it across to the other side. Okay. What else? So creatinine. So creatinine is going to rise when? Yeah, not acutely. So it rises based on your muscle mass, right? This gram is creatinine, 1.1, guaranteed, right? She has a lot of muscle mass. Whereas, a regular gram or an older person is going to have a lower creatinine on average, right? And this guy over here, he has a lot of creatinine as well, right? He has a lot of muscle mass. He's producing this waste product, right? So we had immediate energy. When we took creatine from the store, right? We bought the creatine from that immediate energy for our workout, and then there's the creatine kinase that does it, and that will spill in rhabdo. But once you're all done with all that stuff, you will eventually make creatinine, right? And that's made as a constant rate, right? So some of it is excreted, and some of it is not excreted, right? So we have this constant creatinine that we can always measure on our lab tests, right? So it does not fluctuate acutely. The only reason it would fluctuate is if you had kidney damage, okay?
Maintaining a big muscle mass like that over time eventually cause kidney damage?
No, so muscle mass does not cause kidney damage. So like with actors now, like losing all the weight or losing all the muscle mass, it's more because of the weight of the muscle itself, putting more strain on the bones and putting more strain on their body overall as a stressor. Right? Doing this is a stressful inflammatory process. Right? To build muscle, you have to stretch it and cause micro tears for then it to be then repaired, and you then add more myosin and actin in there for it to be able to grow and get the more muscle volume. Right? But does that cause renal failure? No. Okay. All right. So yeah. So creatinine will rise only with at baseline, only with more muscle mass. But if it rises without a change in muscle mass, and again, you can't go from grandma to this in one day, right? You can't build that muscle in 1 to 2 days. So the creatinine going from 1 to 3 is because of well, maybe you made them. Did you make them dehydrated? That could be it. But the other more likely reason is because of acute kidney injury. All right, so the last thing we kind of touched on already was ratios, right? So the ratio of the BUN to creatinine. So normal is what? Normal creatinine is 1-ish, and normal BUN is 20-ish, right? So normal ratio is 20-ish to 1-ish, right? So 20 to 1, right? So 20 to 1 is a normal ratio. And if you're more than that, that means I had more BUN, 40-ish, right? Or let's say 25-ish, right? To 1. So instead of it being 20, BUN of 18 and a creatinine of 1, it was a BUN of 27 and a creatinine to 1, right? So the reason why that BUN went up was because of what? It could be acute kidney injury, but it could be also a natural physiological process, right? We have who? We have ADH, right? ADH is going to absorb BUN, take it from the urine, put it in the bloodstream. Well, what do we measure BUN at? Or where do we measure BUN at? In the bloodstream, right? So we're going to have a BUN creatinine ratio that is elevated in pre-renal failure, right? And we also talked about some other reasons why that might happen over here, right? When we have a GI bleed or steroid use, that could also be a reason why the BUN creatinine ratio would be greater than 20 to 1, right? So just those 3 reasons, right? Either you have pre-renal failure, you have a GI bleed, or you have steroids, okay? If it's less than 10 to 1, so creatinine is 3 and the BUN is 28, well, that's not 20 to 1. 3 times 20 is 60. I expect 60-ish, right? But if it's less than that, then you're thinking, then it's a problem with ADH. ADH isn't working. Why is ADH not working? Because my kidney is dead, right? I have intra-renal failure. My kidney is done. It's cooked. It has a collecting duct that does not respond to ADH or vasopressin, ADH, vasopressin, DDAP, all the other fun witness protection ADHs, but also it doesn't respond to aldosterone. So aldosterone and ADH don't work, right? So therefore, what's going to happen? what's my ratio going to be? It's going to be low because it's going to try to release ADH. It's going to try to absorb the urea and put it back in the bloodstream, but it doesn't work. So you're going to see a ratio that's less than 10:1 with intra-renal failure. Okay. Also, you're going to see the kidneys don't respond to ADH and aldosterone. Therefore, aldosterone is supposed to absorb sodium, and therefore the sodium is going to be high in the urine when it should be low in the urine if you have if you want to hold on to fluid volume, right?
So does vasopressin raise the blood pressure by its renal effects, or does it bind peripherally, like directly, like say like a levoped?
Yeah, so ADH binds to two receptors, V1 and V2, vasopressin 1 and vasopressin 2 receptors, right? So vasopressin 1 receptors are located on the vessels, right? And they vasopress, they vasoconstrict directly. Vasopressin 2 receptors or 2s are in the tubules, right? So they're the ones that are going to reabsorb urea and water and restore preload or blood volume, venous return. The other one's going to increase afterload or increase blood pressure. So they both increase blood pressure, right?
Gotcha.
And also when you increase that water absorption, that's going to take away thirst as well, right? So yeah, so ADH does both actions.
Okay, gotcha.
Okay, all right. So that's the piece with BUN creatinine, and we'll talk a little bit more about pre-renal, intra-renal, like urine osm. Makes sense, right? If I have ADH as around, but it can't work on the kidneys because the kidneys are dying because they have intra-renal failure, is ADH going to work? No. Can the kidneys concentrate urine? No, the whole way you concentrated urine was with ADH and aldosterone. That was their one only job, was to absorb water from the urine, right? And on this way out, right, it was just say, hey, you come over here, right? So they trigger a little sodium into a little white panel van, right? And then the ADH tricked the urea, right, like it's a dumpster dive right behind Trader Joe's, and then water followed. Okay, so that's the idea. That's how you concentrate. Can you concentrate in pre-renal failure? Yes, you can take sodium and urea out of the urine, therefore the urine sodium and urine urea will be low in pre-renal failure, right? As we can see here, in pre-renal failure, the urine sodium is low and the urea will be low as well, right? And the urine osmolarity, the concentration of the urine, is very, very high because you took all the water out of it, right? The specific gravity is the same thing as urine osmolarity, it's the same thing as urine osmolality, the same thing as concentration. Okay, and then intrarenal failure is it doesn't work, right? It can't respond to, it doesn't respond to ADH or aldosterone, so therefore it can't concentrate urine. Therefore, the concentration of the urine is what? If you can't concentrate it, it's going to be what? It's going to be dilute, right? Very, very low, very dilute. Right? And the urine sodium, you couldn't take that sodium from the urine and put it back in the bloodstream. Therefore, the urine sodium is high in that case. All right, some more labs. Oh my gosh. So we talked about BUN creatinine. We kind of talked a little preamble on urine studies like urine specific gravity, urine sodium, urine urea, and all those other fun things. But now we're going to talk a little bit more about those just to kind of solidify it, right? So the urine excretes stuff, right? One of the things it does excrete is sodium. There's something called a FeNA, right? Or it sounds like one of my applications for college, but I got a FeNA, all right? It's also, they help do hurricane aid too, right? Anyways, we have, it's called a fractional excretion of sodium, but it's not useful, right? There's this fractional excretion of urea as well. What's really helpful is just the actual urea and actual sodium in the urine, right? They will compare with a serum, just so they can see if there's something weird like a DI or SI developing, but the urine sodium and the urine urea secondarily are the most important things that we want to grab. Third thing being specific gravity, right? Because there are solutes. Those are things that are dissolved in the water, in the urine, that we can take a look at, see if there's something there that could be forming crystals, for instance, right? So there's casts and there's crystals that might form in the urine that we can do studies on, right? Do further studies on if something is suspicious, right? So if you have and again, there's like 7 different names. Like they subscribe to the same school as ADH, right? There's ADH, vasopressin, DDAVP. There's also specific gravity, concentration, osmolality, dark, dilute, right? So they all mean the same thing. Just pick one you like, right? I like concentrated, right? It's either concentrated or it's not. If it's not, it's dilute, right? So if you're concentrated, that means all these numbers are high, right? There's no other trick to it, right? So if you have an elevated specific gravity, that means you have an elevated urine, an elevated osmolarity, right? So we talked about concentrating, right? How do you concentrate things in your body? Your kidney is doing this, right? And what does it do? It's absorbing sodium and water, right? And it's absorbing urea, okay? So urea gets absorbed. Who does that? Starts with an A, so does the sodium water one. ADH, right? Unless he's in witness protection, he's then called vasopressin, right? But you got ADH absorbs urea, and then water will follow, and that will then make my urine what? Dilute, concentrated, high specific gravity, low specific gravity, high osmolarity, low osmolarity, which one? More concentrated, right? So then that you just kind of translate that. That means elevated spec grav, elevated osm, elevated osmolality, right? So if my ADH is working, like I have like an inappropriate amount of it, and it's like a syndrome of some sort, like a SIADH, that can make my urine very, very concentrated, right? And my serum would be dilute. And we'll talk about that in endocrine. We kind of play with the numbers a little bit more, right? But ADH and aldosterone, right? Those are the two things that are going to concentrate urine, right? Aldosterone works just right above ADH and it absorbs what? Sodium and water, right? It's going to work on the sodium potassium channels. It's absorbing sodium and water, right? So this nephron is functional during pre-renal failure, right? When I have a kidney that's functional, it gets less flow. It's going to try to release aldosterone and ADH to try to improve flow, right? Improve blood pressure. So, and then if it responds to it, and it's going to absorb sodium and water, and it's going to absorb urea, and you're going to be able to see those on the UA or the urine lights, right? So you can see urine sodium is operational when aldosterone is working, right? When aldosterone is working, it's pulling sodium out of the urine, it's making it low or high, making it low, right? That's what it's doing. That's its job. Its job is to absorb sodium and put it back in the bloodstream so that then water will follow and hopefully we restore blood volume, right? And then we talked about the concentration. So if it takes the sodium and water out of the urine, the sodium's low, but what's the water content? Also low, right? So it took the water out of the urine, right? It made the urine dark, it made the urine concentrated, it made the urine have a high concentration, a high specific gravity, a high urine osm, a higher urine osmolarity, right? So you can see here the specific gravity is actually not there, but it's on a different table, sorry. But the urine, the spec grav, right? Specific gravity is also going to be high, right? So specific gravity is high, the urine sodium is low, the urine urea is low because ADH is working, and those are the things that we are going to be looking at. Right there it is, right there. Sorry, it was disguised as osm. It's under witness protection. So osm, osmolarity, specific gravity, concentration. These all mean the same thing, right? So it's concentrating. It's able to concentrate things, right? So a kidney that works can concentrate things. A kidney that doesn't work, can it concentrate things? A kidney that's dead, do dead things work? No, right? So dead things don't work. So write that down, right? Dead things don't work. So intra-renal failure is a dead kidney or a dying kidney, right? So it's not able to respond to aldosterone or to ADH. So if it can't respond because it's dying, right? So it's like, aldosterone knocks the door. Are you able to work today? It's like, I'm on my deathbed. What are you talking about? I'm not going to work today. I'm not going to absorb urea, right? Therefore, my urea is going to waste right into the urine, right? I'm not going to absorb sodium. All the sodium is going to go in the urine, and the sodium will be what? High. Right? And then since the sodium is in the urine, what's going to follow? Water, right? So is there going to be a lot of water or little water in the urine? There's going to be a lot of water. And a lot of water makes something less or more concentrated? Makes it less concentrated or dilute or specific gravity that is low or low osm, right? Any one of those things means it's low, right? So specific gravity is going to be the same as the serum. You can measure specific gravity of the serum too, right? But we usually measure the osmolarity of the serum, right? Usually the osmolarity of the serum is about 280 to 300, right? So you can see here, I think it's coming up, but the serum, the osmolarity will be the same, right? So it's 280, 280. Urine osm and serum osm are exactly the same because it just went right through the kidney, right? It didn't do anything to raise the serum osm, which is what it should do if your blood pressure is low, if you have pre-renal failure or such, okay? And as you mentioned, the FENA is another cool formula that these nephrologists came up with. Again, we talked about at the beginning, nothing's much changed in renal in like 20, 30 years, but they kind of add new things. Hey, you can do this. And then someone says, well, actually, that's not accurate if you're on diuretics. It's like, no one's on diuretics in my practice. Like, everybody, sure. Yeah, everybody gets diuretics, right? So that's more of like an outpatient thing. They might look at that, right? That's just looking at how much sodium they're excreting over time. Okay, and it has the same numbers too. It's gonna be low if you have low sodium, urine sodium. All right, so then so that's specific gravity and concentration. And then what about casts? We've been talking about casts a little bit, right? Like RBC casts or WBC casts, and things we're taking like a Xerox of, right? Like if you're like ghost hunting and like you take a little big picture of the ghost, and then you see a little impression of it. It's the same thing, right? You do an impression of the nephron, right? And then all that's going to come out in the urine. You're like, cool, look what I got. It's like, okay, all right, you can go home now. I don't want to see that, right? But it's an impression of the nephron, right? And why would you have an impression of the nephron if it is dying, right? So it's like shedding like a snake. So these little casts of the nephron. So in acute tubular necrosis, for instance, you're going to see these casts, right? And they are muddy brown casts. And that is like pathognomonic. That is like what you always see with someone with ATN. So ATN has these muddy brown casts. Specific gravity is 1010. What's normal specific gravity? I didn't point it out, but it's usually 1010 to 1020, or sorry, 1020 to 1040, right? So it's going to be a low specific gravity. That means I have low concentration or high concentration of urine. Low concentration, low spec grav, low urine osm, low, I have a dilute urine, right? Why is it dilute? Dead things don't work, right? So I have intra-renal failure, I have acute tubular necrosis, right? So then, so I got muddy brown cast is classic for ATN. And then RBCs is glomerulonephritis. We kind of touched on that just briefly, right? If I'm attacking my glomerulus, it's going to get very, very leaky. It's going to leak proteins and RBCs, right? And I'm going to see some WBC casts a little bit as well. So maybe some even eosinophils, because that's what happens with like autoimmune reactions. All right, and then another like classic one is waxy casts. Like a waxy cast, like just like someone's going away, like back in like Greece times, right? All the way back in the Odysseus times. Say, hey, I'm gonna make a bust of you. It's like I'm gonna cast you, and then as you go off to sea, I don't know if you'll come back. If you do come back in 20 years, okay, right? But at least I got something to look at you with, right? So I can see a image of you. And I'm going to make it in wax, right? So it's a waxy cast. As your kidneys start dying with chronic kidney disease, you're going to make a bust of it, and you're going to make a little picture of it, and that'll be you can see that on the UA. We can see they got waxy casts, and waxy casts are a cast of the kidneys before they end up dying, right? There's 5 stages of CKD, and once you get to 3, 4, 5, it's irreversible. So that's the time now to get your casts of your kidney. Okay, and then there's some pre-renal issues. These are all intra-renal, right? And then we have pre-renal things, so like hyaline casts. So hyaline casts are like glass-like. They are seen in dehydration. So if someone's dehydrated, pre-renal failure, right? And if you see hyaline casts on the UA, that means they have a low volume state, right? So that's a clue to it, right? So I can't figure out what the renal failure is. Well, you can look at BUN Creatinine ratio, but if you see waxy casts, it's like the reason why the creatinine is elevated is because they had chronic kidney disease, or you see hyaline casts because they have dehydration of some sort. Okay, and then acidic, that happens like an acidic concentrated urine. Okay, and then there's other crystals that can form that we mentioned. Crystals can form from like acyclovir, it can form from like Bactrim, it can form from all kinds of other crystals that develop over time, like calcium oxalate stones, all kinds of other fun stones that can develop and form. What kind of renal failure is that? That was post-renal failure. If you develop stones, nephrolithiasis, that's going to cause a post-renal failure of some sort, right? It usually has to be bilateral. Right? And actually, this is the reason why the FDA was invented. So the Federal Drug and Food Administration, or the Food and Drug Administration of the government, was invented because of kidney stones, right? So back in the 1936, I think it was, somewhere back there in I think it was pre-World War. Either way, they, kids, they didn't want to take antibiotics. It tasted crap, right? It was really, really bitter. So what they did is said, you know what I'm going to sweeten it with? Antifreeze. So they put antifreeze inside the medicine and say, yeah, just take it. It's good, right? And then kids died, and then now they said, we got to step up. We can't let this happen again. We can't put antifreeze in our medicine, right? So they took out this little preservative that they had there. What was it called? 1938. There it is, right? It was a diethylene glycol, right? Ethylene glycol is antifreeze, right? So then we know that ethylene glycol forms kidney stones, right? So the FDA was invented for this reason. Okay, so that we have safety measures in place. Because before this, it was literally the Wild West in the 1800s. But you can throw any drug you want. Little guy in a little wagon could show up. It's like, look at all the medicines I got, right? And people would take it. Doctors might even prescribe to it, just like with the benzosphenobarb situation back. It's like, oh, they just had good salesmen, right? The little snake oil salesmen were selling all these things, and they had no regulation at all about what was actually government approved and what was not, right? Just like what in like the early 20s and 30s, actresses were dying left and right because they're actually using radiation pigment, like uranium, inside their makeup powder, right? Just so they would glow on screen. So yeah, that wasn't a healthy glow, right? What's that? Radium girls, yeah. So that's the idea. So you want to, there's some regulation nowadays. Okay, so muddy brown calves were what again? That was ATN, right? RBC casts you might see, WC casts you might see, and then the waxy casts were chronic kidney disease. And this is added to all the stuff we looked at for pre-renal, for elevated BUN creatinine ratios, right? Intrinsic renal, we're looking for like myoglobin, creatine kinase, other things that are some other unique things that might cause a renal failure of some sort.